ايش في
اريح للكل الزوم.
اوكي ايوه
شايفينها هلا؟
واضحة، ايوه بس كبرها.
رح تكبرها.
خلاص خلاص
اوكي.
كبرت. fractures about shoulder joint. دكتور جون، كان بدي اقول لك حاجة قبل ما تبدا، الله يحفظك.
ايه
الشباب معاهم طبعا الأوسكي في شهر 7 في مصر، طبعا أنت عارف في بداية 7.
ايه.
فهم عاوزين منك يعني المحاضرة الجاية نعمل لهم ريفيو كورس مثلا، أسبوع للسبورتس مثلا، أسبوع
بعمل
للسباين، أسبوع
لهم، خليهم يبعثوا لي شو بدهم وبعطيهم يكرم عيونهم.
تسلم والله. أمس كلموني، أنا قعدت معهم قالوا كلمة دكتور جون يعطينا ريفيو كورس على ريجونز معينة، أو مثلا بس
يعيدوا لي
يصب
شو بدهم، بعطيهم كل شيء.
اكثر شيء سبورت وسباين، هذا الديفكتس اللي
نعطيهم
معاهم
مرة
يعني اكثر شيء.
الجاية إذا بدهم سبورت انجريز. شو رأيك؟
خلاص خلاص، المره الجايه سبورت انجليز نبدا فيها. خلاص
خلص.
اتفقنا.
اوكي.
شكرا يا باشا،
اليوم رح
شكرا
بحكي
لك.
عن fractures about the shoulder joint.
اوكي
اللكشة في عندي فوق ال 600 سلايد.
ما شاء
we're
الله.
going to discuss the sternoclavicular joint and injuries, the medial physial clavicle fractures, the sternoclavicular joint osteoarthritis, clavicle fractures, acromioclavicular injuries, floating shoulder, non-union of the clavicular fracture, and if we have time, we'll go into the proximal humeral fractures. We'll start with the sternoclavicular joint. عم تسمعوا يا شباب؟ عم تسمعوا؟ عم تسمعوا؟ الصوت منيح؟ خالد.
دكتور جون، ايوه ايوه معك واضح.
اوكي الصوت منيح.
صوت منيح.
The sternoclavicular joint is formed by the articulation between the medial end of the clavicle and the sternal manubrium, and plays a vital role in the attachment of the shoulder girdle to the body. It is involved in the attachment. It is the main attachment. It is the only true articular connection between the upper limb and the axial skeleton, as the scapulothoracic joint is not a true synovial joint. The sternoclavicular joint is a synovial joint. This is for the residents. Don't forget that it is a synovial joint. Oh, it is a synovial joint with largely incongruent articular surfaces. On the clavicular side, the surface is saddle-shaped مثل خرج الحصان, with a concavity on the anteroposterior plane and the convexity on the vertical plane. بتصير مثل الsaddle of a horse. This shows you the sternoclavicular joint. It consists of the interclavicular ligaments, the anterior and posterior sternoclavicular ligaments, and is supported by the subclavius muscle, and more mesial is the coracoclavicular ligament. There are muscles about the sternoclavicular joint, which are the sternocleidomastoid, and even you have the trapezius muscle. This is not shown in this slide. If you palpate the joint, you should examine it carefully. Palpate over the anterior joint line for pain and extruded disc, external and internal rotation with the elbow bent at 90 degrees and the arm at 90 degrees abduction. Rotate the arm from external to internal. You have to be rotating with one arm and the other hand is on the joint. You can feel whether the joint is stable or not, whether it's undergoing protraction or retraction, whether there is displacement anteriorly or posteriorly or superiorly, or whether there's clicking of the sternoclavicular joint. These are how you should examine the joint. Between the articular surfaces lies a fibrocartilaginous disc, similar to the meniscus of the knee. This separates the joint into a medial and lateral compartment and is attached to the capsule at its periphery to the superior surface of the medial clavicle and the first costal cartilage inferiorly. Contrary to most classic anatomical texts, a recent anatomical study has shown that the superior part of the disc inserts into the superior third of the medial end of the clavicle. Killer to tell you that the meniscus divides the joints into two parts, and the upper part of the meniscus unites with the most mesial part of the clavicle. So you have to pay attention. The disc over here is protective. And what is characteristic is that it involutes at an early adolescent age. Let's speak about articular cartilage. It only covers the lower two-thirds of the medial clavicle. You see, this is the articular cartilage over here. Over here, you don't have articular cartilage. Despite the incongruent articular surfaces and small surface area of the joint, the sternoclavicular joint is extremely stable owing to the effect of strong static, both intrinsic and extrinsic, and dynamic soft tissue stabilizers. Now I'm going to show you a table. This table, you should look at it. You should memorize it. What are the static stabilizers and the dynamic stabilizers of the sternoclavicular joint? The static stabilizers are the capsule, and the intrinsic stabilizers include the intra-articular disc, the ligaments, the anterior sternoclavicular ligament, and the posterior sternoclavicular ligaments. The extrinsic stabilizers are the interclavicular ligaments, which are between two clavicles and rather a bit posterior, and you have the costoclavicular, which extends from the ribs, the first rib, to the inferior aspect of the clavicle. What about the dynamic stabilizers? Don't forget you have the subclavius muscle, which lies more laterally between the clavicle and the first rib. You have the sternocleidomastoid on the dorsum aspect and medial aspect of the clavicle. And don't forget about the pectoralis major muscle. One is from posterior, and the sternocleidomastoid is more or less anterior. These are dynamic stabilizers. The anterior and posterior sternoclavicular ligaments are formed by thickenings in the capsule and are the most important contributors to the anteroposterior stability. The intra-articular fibrocartilaginous disc resists. I repeat, this is a very important function. The intra-articular fibrocartilaginous disc resists medial translation of the clavicle. This is a picturesque view. You see the articular disc, which attaches through the capsule to the inner aspect of the clavicle over here. And over here, you have a connection with the first rib. Over here, you have the manubrium. Over here, you have the interclavicular ligaments and the first rib. There are connections between the rib and the clavicle, the rib and the clavicle. All these are connected to give stability. Some are dynamic and some are static. As a result, the disc can be prone to shearing injury, usually as a degenerate tear, but occasionally as an acute incident. The interclavicular ligament passes between the medial ends of both clavicles via the posterior aspect of the sternal notch and resists clavicular superior translation from gravity or forceful depression of the upper limb. So you have to realize and learn these. Learn it, because by learning them, you will understand more about anterior and posterior sternoclavicular dislocations. The costoclavicular ligament passes from the inferior aspect of the medial clavicle to the first rib and or first costal cartilage. It is an important restraint when the clavicle is elevated. It tells the clavicle, hey, where are you going? I'm connected to the first rib, and at your lower aspect is me, which is the costoclavicular ligament. It prevents it from dorsal displacement. The dynamic stabilizers form a muscular tendinous envelope around the joint. So we have so much stabilization. We have so many connections that gives us a solid and stable joint. And never forget that it is the sternoclavicular, the acromioclavicular, the clavicle are what hold the upper extremity in relation to the rest of the body. That's why we have so many connections so as to create stability. The clavicle is a very important structure. Don't disvalue it. The sternocleidomastoid and pectoralis major tendons lie anterior and posterior to the sternoclavicular joint, respectively, and play a role in anterior and posterior stability, whilst the subclavis passes from the inferior aspect of the clavicle to the first rib, providing superior stability as well as an additional anterior superior component. So repeatedly look at it. In green, you see the subclavius muscle. This is very important. Slightly mesial to it, you have the coracoclavicular ligament. We have many muscles which are attached to the clavicle laterally, and they further stabilize the shoulder. Several vital structures lie posterior to the sternoclavicular joint. I tell this to the young residents, and I expect the senior residents to know a lot about it. What are the structures that lie posterior to the sternoclavicular joint? The great vessels of the neck, esophagus, and trachea. These are at potential risk following posterior dislocations. A layer formed by the sternothyroid and sternohyoid muscles lie between these structures. They protect these structures, but it's not enough. Not enough together with the joint capsule. These are very close to the sternoclavicular joint. The epiphysis of the medial end of the clavicle is the first epiphysis to appear in utero and the last to close. This is of relevance because the physis at the medial end of the clavicle is weaker than the sternoclavicular joint ligaments. Significant traumatic injuries before the physeal closure under the age of 25 years. Don't forget that the physis and the bone to appear in the clavicle is the first, and the physis is the last to close, which is at between 22 and 25 years. And this may result in a fracture through the physis. And this is a Salter-Harris 2 fracture rather than a true sternoclavicular joint dislocation. Now, we know that many of these injuries occur in sports. When you get such a patient, you should be aware of this. Ya tara, is it a sternoclavicular joint dislocation or is it a physeal fracture? Keep this in mind. The sternoclavicular joint moves in 3 planes: retraction, protraction, elevation, depression, and rotation. So it moves nearly in every single direction. Why does it move? Because it helps in putting the glenoid in such a function as needed so as to be able to perform the function demanded from it. Movement at the sternoclavicular joint and the acromioclavicular joint allows the scapula to move around the thorax to position the glenoid in the optimal location to maintain glenohumeral joint congruency for the upper limb positioning. So you look at the sternoclavicular and say, my God, it's a simple joint. No, the acromioclavicular joint, no, they are both significant joints. They are what control the position of the glenoid in the glenohumeral joint. So keep this in mind. You should take a proper history and examination, as with any upper limb complaint. It is important to consider the age. Which side? Is it the right or left? Where did it occur? Did it occur in sports or a car accident? Aspirations and occupation of the patient. An acute injury typically involves a high energy mechanism, and a sternoclavicular joint injury may be missed in the presence of more dramatic components. So other accidents, other injuries can cover up. But if you are an alert resident, if you are an alert physician, you should always keep in mind all structures, not concentrate on one structure and forget the other. It's awful, and it can be life-threatening if you forget to examine and that the patient has a posterior dislocation of the sternoclavicular joint. So keep this in mind, my children, the residents. Keep this in mind. Details of the injury should be taken, including the direction of the impact should be thought. Up to 30% of acute posterior dislocations develop mediastinal compromise concerning features. The patient can have dyspnea, dysphonia, dysphagia, coughing, venous congestion of the ipsilateral arm, and should be considered a medical emergency. Don't miss this. And many times you have to make sure that there's a cardiovascular surgeon near your right hand. Patients usually present with pain over the sternoclavicular joint in the presence of a deformity, a prominence of the medial clavicle in anterior dislocations, and a defect lateral to the sternum in a posterior dislocation. Be careful. It's a simple thing. Use your finger. And if you have swelling, try and palpate deep. You can diagnose it by just one finger putting on the sternoclavicular joint. Besides the clinical presentation, besides the pain, patients presenting with more chronic problems, a history of previous trauma, or a change of activity preceding the onset of symptoms may be relevant. In younger patients, complaints of pain, clicking, a feeling of instability, or even recurrent dislocation in the absence of injury may suggest an atraumatic instability. We do see these patients. Example would be Marfan syndrome. Okay. And of course, Ehlers-Danlos syndrome. All the patients may present with a pain and restriction of movement associated with swelling over the medial end of the clavicle in keeping with osteoarthritis. Sternoclavicular joint examination is predominantly based on comparison and any asymmetry between sides. God gave us an advantage of having two extremities, and one is always available for comparison. This requires exposure of the upper trunk to allow for comparison of both shoulder girdles. It is really embarrassing to you as an orthopedic surgeon to get the patient in the emergency room and she refuses or he refuses to undress. You should always examine the patient when undressed, and you tell the family and the patient that this is for her advantage. You should look at the clavicles, the glenohumeral joints, and the scapulothoracic movements. There may be obvious asymmetry between the patient's sternoclavicular joints with a lump present on the affected side. That is, if it's an anterior dislocation. It is important to determine whether this is soft, representing an effusion or synovitis, secondary to an inflammatory arthropathy or infection, or hard, which could represent either a chronic anterior dislocation of the medial end of the clavicle or an osteophyte secondary to osteoarthritis. So you should examine your patients carefully. Movements at the sternoclavicular joint are intimately related to the rest of the shoulder girdle, so that assessment of the acromioclavicular joint, the glenohumeral joint, and the scapulothoracic movements are essential to identify any confounding pathology. Both the sternoclavicular joints should be examined and compared in three planes of movement: external and internal rotation, with the elbow bent at 90 degrees and the arm at 90 degrees of abduction. And you do the following movement that I told you with your finger on that sternoclavicular joint, and you will elicit the problem if there is one. Whilst examining the range of motion, it is important that the examiner places a hand over the anterior joint to feel for any abnormal movement and clicking, popping, crepitus at the joint during movement may suggest degenerative changes, or in a younger patient, a disc tear. The medial end of the clavicle may sublux or even dislocate anteriorly in patients with instability. In this instance, broader assessment of the stabilizing soft tissue envelope, particularly looking at the sternocleidomastoid and the sternal part of the pectoralis major for muscle sequencing over activity should be undertaken. Don't forget this, please don't. Don't forget this examination. Don't. Now, let's come to each one individually. Sternoclavicular joint instability can be classified by the direction, whether it's anterior or posterior, by severity, sprain, subluxation, or dislocation, often referred to as type 1, type 2, or 3, or by whether it is acute, recurrent, or persistent, meaning that it is chronic and unreduced. Whilst these classifications are descriptive, none of them are able to take into account the traumatic or atraumatic nature of the instability. However, a classification system that is a direct derivation of the Stanmore tripolar instability triangle for the glenohumeral joint has recently been described for the sternoclavicular joint. This is the Stanmore sternoclavicular instability classification, and there are 3 polar groups. Type 1 is traumatic, type 2 is atraumatic, and type 3 is muscle patterning, a muscle which behaves in an awkward way. The type 1 traumatic structural group comprises traumatic subluxations and dislocations of the sternoclavicular joint, as well as medial physeal fracture displacement. This is the Stanmore classification. You have over here, up, you have the traumatic. On the right hand, you have the atraumatic, and you have the muscle patterning non-structural. And this is, if you're asked, what is the Stanmore triangle? You should mention this, and I'll go into it. A type 2 atraumatic structural group comprises conditions which lead to laxity of the restraining ligaments and includes connective tissue disorders, Marfan's, Ehlers-Danlos syndrome, degenerative arthritis, inflammatory arthritis, infection, and clavicular shortening secondary to previous malunion. Type 3, what I mean now, and I'm adding to the group, is the muscle patterning group. And this can occur in isolation and is most commonly due to an overactive or aberrant pectoralis major muscle, but it can also develop secondary to a type 1 or type 2 disorder. This occurs when you have an abnormal portion of a muscle begins to function in an awkward way against whatever is opposing it. And as a result, this can lead to a pseudo-subluxation. So keep this in mind. A continuum exists between the groups. Therefore, a patient with an initial type 2 instability can develop a secondary muscle patterning type 3 over time, and this patient would be then classified as type 2 and 3. This is the classification they have been able to make for sternoclavicular joint dislocation. The effect of any treatment can also be monitored using the Stanmode sternoclavicular joint instability classification system. Patients migrate around the triangle depending on the presenting pathology and how that changes over time as their treatment progresses. Type 1 traumatic structure. Traumatic sternoclavicular joint dislocations, they are rare. They account for less than 1% of the upper limb injuries and usually occur as a result of a high energy impact. Now, I'm sure some of you, when you are listening to me and I tell you that these are rare, and I tell you it's less than 1% of upper limb injuries, but it is in these rare injuries that you are able to detect, you prove that you are a capable orthopedic surgeon. The force is usually indirect and follows an impact either to the front or back of the humeral head. Pay attention. It follows an impact to the front or back of the humeral head. The force vector is then transferred along the clavicle, resulting in a disruption of the sternoclavicular joints, restraining soft tissues. If the scapula is protracted at the time of impact, a posterior dislocation is more likely. And if a scapula is retracted, it is more likely to dislocate anteriorly. And this is what I'm going to show. Look at the impact. If the impact is from posterior, you will see that the clavicle would displace posteriorly. So posterior impact to the shoulder or the head of the shoulder promotes posterior dislocation of the clavicle. If you apply a force anteriorly to the glenohumeral joint, the dislocation will occur anteriorly in the sternoclavicular joint. So keep this in mind. Look at this photo, remember it. Less frequently, a direct anterior blow to the clavicle can drive the medial end posteriorly into the mediastinum. Biomechanical studies have shown that the force required to dislocate the sternoclavicular joint posteriorly is 50% greater than that required to cause an anterior displacement. Okay, don't forget this. If you are asked, where would you need more force, anteriorly or posteriorly, if you have a direct impact? You need for a more impact posteriorly. I have a meeting, Jack. I'll be meeting. Okay, so let's make this clear. A meta-analysis of 140 adolescents with posterior sternoclavicular dislocation reported that 71% occurred during sporting activities. So keep this, whoever's interested in sporting injuries, that this is one of the injuries. Although still rare, this requires particular vigilance by pitch side sports physicians and physiotherapists, as over 30% of patients following an acute posterior sternoclavicular joint dislocation, and they would develop mediastinal pressure symptoms.
دكتور جون
ايه
دكتور جون
شو خالد؟
الصورة مثبتة على سلايد واحد بالها شوية كم دقيقتين يمكن.
شو بدي أعمل؟
عيدها يعني يعني مرة ثانية أو تسوي ريفرشمنت
The
مرة ثانية
slide,
تدخلها.
the slide.
أيوه أيوه لأني مثبتها على سلايد واحد على المثلث هذاك
I
اللي
didn't
كانت
get ما
ترينجلر.
بسمع يعني هلا اذا غيرت ما بتغير؟ بلا عم بتغير معي.
لا
هلا
معك يمكن لكن معنا لا.
ما بتغير يحرق.
معنا ما
برجع
أيه.
برجع بفوت.
ارجع فوت مرة ثانية.
لا برجع بفوت.
أيه.
هلا انا سلايد 50 اوكي رح برجع بفوت. واضح هلا؟ خالد شايفين هلا؟ خالد يا خالد am I
واضحة
clear؟
يا
واضحة؟
كلير. واضحة خلاص. أوكي.
A meta-analysis of 140 adolescents with posterior sternoclavicular dislocation reported that 71% occurred during sporting activities. Although still rare, this requires particular vigilance by pitchside sports physicians and physiotherapists, as over 30% of patients following acute posterior sternoclavicular joint dislocation develop mediastinal pressure symptoms. يعني بدي أقول لكم, if you have people playing football and they have an injury that would cause a posterior sternoclavicular joint dysplasia, the physician can be a physiotherapist, he can be an orthopedic man. He should be aware that this patient who has had this injury has a 30% risk of developing mediastinal pressure symptoms. And he should be aware of this because he can lose the patient if he's not aware. Acute symptoms include dyspnea in 14%, dysphagia 22.5% due to pressure on the trachea and esophagus, venous congestion or edema of the ipsilateral arm due to compression of the vessels, and this occurs in 14%. Less common complications of posterior dislocation include a mediastinal hematoma, vessel laceration leading to death, stroke, pneumomediastinum, pneumohemothorax, venous thromboembolism, which occurs in 0.72 to 2.9%. As a result, an acute posterior sternoclavicular dislocation should be treated as a medical emergency. Patients presenting more chronically often complain of pain and deformity over the sternoclavicular joint. In certain patients, as the medial clavicle has been pushed posteriorly, the whole of the shoulder girdle has rotated anteriorly and superiorly. As a result, the scapula tends to sit in a more superior and protracted position. Patients may complain of problems with glenohumeral function and of asymmetrical scapular protraction, which leads to, for example, it can make sitting in a high back chair بيقعدوا على كرسي عالي من ورا. They are uncomfortable as the medial scapula adopts to a winged position, as is shown in this slide. You can see that the scapula above in the slide on the right hand is more elevated and more protruded than the scapula on the right side. So when they sit, all the pressure is on the scapula, and the patient would be very uncomfortable, and they demand that their situation should be corrected. On examination, a patient with an anterior sternoclavicular dislocation presents with an obvious forward displacement of the clavicle, while a patient with a posterior dislocation demonstrates an asymmetry compared with the contralateral side, with diminution of the entire clavicular contour on the affected side. The whole contour is changed. If you notice, I'm going through this in detail so that you'll never forget it. We have 630 slides, and I've put so many slides so that you'll never forget each of the components of this lecture. I know I might bore you, but I'm trying my best to make it more interesting. However, following an acute posterior dislocation, significant soft tissue swelling often occurs over the first few days, making a posterior deformity less obvious. It can be difficult to clinically distinguish a medial clavicular physis fracture dislocation from a true sternoclavicular joint dislocation. A high clinical suspicion for medial clavicle physeal injury should remain for anyone under the age of 25 years. Traditionally, initial investigations following a sternoclavicular joint include plain radiography using the serendipity view. This is how we take the serendipity view. The patient is lying supine with a cassette underneath the shoulder, and the tube is angulated 45 to 60 with the horizontal, and you shoot it of the clavicle. It would tell you whether it's anterior or posterior. However, these are often difficult to interpret. A plain chest X-ray may be considered following an acute injury to check for associated pneumothorax secondary to rib fractures. Currently, the investigation of choice is a CT scan, or in the case of a posterior dislocation, a CT angiogram. This should be undertaken as a matter of urgency in the acute situation, should there be any concern with regards to mediastinal compromise. A CT scan can accurately assess the position of the medial end of the clavicle with regards to the sternum and the contralateral sternoclavicular joint. It can also differentiate between a dislocation and the medial physeal injury. A CT angiogram additionally shows the arch of the aorta and great vessels in relation to the medial clavicle. This tells you more about the sternoclavicular joint dislocation. You can see these views. You can see the manubrium. You can see the position of the clavicle and its relation and compare it to both sides. This is a CT scan showing one of the clavicles being displaced posteriorly. You can see it in addition to some fractures of the rib. So a CT scan tells us more and more about dislocations. It tells us about the relation to the surrounding structures. Okay? And when you suspect a vascular injury, you should do a CT angiogram. Okay? An MRI scan has poorer bony resolution than a CT scan, but is able to more effectively demonstrate the ligamentous structures following subluxation and recurrent dislocation. It is also able to assess the intra-articular disc for injury and the condition of the adjacent neurovascular anatomy. Management of type 1 sternoclavicular joint instability depends on the severity of the injury, the direction of the instability, and the time from injury. Anterior, posterior, undisplaced ligamentous sprains and subluxations of the sternoclavicular joint, namely grades 1 and 2, and minimally displaced medial physeal fractures can usually be treated with conservative measures. Initial reassurance, oral analgesia, and ice coupled with short periods of immobilization in a sling is usually sufficient. The patient should be advised to avoid re-injury for 3 months, and he should avoid contact sports or other high-risk activities until there is a resolution of clinical symptoms. There is no brace or support that will provide any extra protection to the sternoclavicular joint on return to contact sports. The management of sternoclavicular joint dislocations, grade 3, is dependent on the direction and the time after injury. If it's less than 48 hours or later, this is the limit. For anterior dislocations that are less than 48 hours post-injury, a closed reduction under sedation or general anesthetic can be attempted with a bolster, meaning a support between the scapula in the back, under the patient, between their scapulae. The clavicle is pushed into posterior direction. The sternoclavicular joint usually reduces easily, but sometimes traction to the arm is necessary to pull the clavicle laterally. The arms should then be kept in a sling for 4 weeks in internal rotation. But unfortunately, in over 50% of cases, the sternoclavicular joint redislocates. The majority of surgeons adopt a wait and see policy following an anterior dislocation. Over a period of 3 to 6 months, many patients' symptoms settle with conservative management, including a combination of physiotherapy and time. A recent study has described a surgical repair technique for the treatment of first-time traumatic anterior dislocations of the sternoclavicular joint in younger patients involved in contact sports. They undergo a repair and plication of the anterior capsule augmented with internal bracing in 6 patients following a first-time anterior dislocation. At a median follow-up of 28.2 months, range was 24 to 35 months. None of the patients had sustained a further dislocation, and they had all returned to their pre-injury level of sport. If a patient continues to experience significant symptoms despite inadequate period of conservative management, or if they sustain further recurrent dislocations, then surgical stabilization may be considered. This would usually require reconstruction using an autograft, allograft, or synthetic ligament. What about the posterior sternoclavicular dislocation? There is a greater need to reduce and maintain reduction of the joint. In the acute situation, in the face of mediastinal compromise, this is particularly the case. A chronic posterior dislocation may affect shoulder girdle function due to protraction of the scapula, and there are concerns of potentially developing erosion to the subclavian artery with time, or thoracic duct injury and tracheoesophageal fistula. So this should be taken seriously. Although these complications are rare, their probability will increase over time, and so operative reduction and stabilization may perhaps be of more consideration the younger the patient. The younger the patient. The older the patient, no, but the younger the patient, it is. Closed reduction is only generally considered if the injury is less than 48 hours old. Closed reduction maneuvers after 48 hours are discouraged, as they may result in tearing of the posterior structures, owing to the formation of adhesions. Closed reduction is undertaken using a general anesthetic and a radiolucent table, allowing access for fluoroscopy. A bolster again is placed posteriorly between the scapula and the patient. Abduction, traction, extension are applied to the affected arm, and a tower clip is used to grasp the medial clavicle and pull it anteriorly. But, I repeat, you need a vascular surgeon close by, because many times as you're reducing it, the subclavian artery can tear. These lie just posterior. Beware of this. Closed reduction of an acute posterior dislocation is difficult, with a reported success rate of approximately 50% in those cases attempted within 48 hours, and of 31% between the 2nd and 5th day. A multi-center series of 30 acute posterior dislocations of the 16 cases that were treated within 48 hours, seven required an open reduction, and 2 of the 7 cases that could be reduced redislocated within 7 days and required a subsequent open stabilization. If closed reduction is successful due to soft tissue swelling and difficulties in interpreting fluoroscopy images around the sternoclavicle joint, a repeated CT scan to confirm the reduction has been maintained and should be undertaken the next day. Considering the high potential failure rate for a closed reduction, it is important to consider preoperatively the potential need to proceed to an open reduction and stabilization. This may mean that the patient requires transfer, I repeat, transfer to an appropriate facility where a cardiovascular cover is available. Open reduction in the acute phase is usually technically easier due to the lack of adhesions and the consequent diminished risk to posterior mediastinal structures. In the chronic situation, preoperative planning with a CT and arteriogram, with discussion and collaboration with a cardiothoracic surgeon are essential. Work together. There's no shame in working together. Any likely adhesions to the posterior mediastinal vascular structure with the brachiocephalic veins in particular can then be anticipated. A transverse incision is made over the sternoclavicular joint, and after freeing any adhesions, the clavicle is reduced by anterior and laterally directed traction applied through a towel clip or bone-holding forceps. The normal capsular and ligamentous stabilizers are usually only partially repairable and are not biomechanically sufficient to maintain the reduction. And as a result, an open reduction will usually require some form of additional reconstruction. Various types of wires and pins have been used to stabilize the joint. However, due to reported lethal complications, these techniques have, in the most part, been abandoned. Reconstruction using sutures alone through osseous drill holes or suture anchors have been reported, but with only marginal biomechanical results. The most recent trend has been towards reconstruction techniques using autograft, palmaris longus, semitendinosus, gracilis, or sternocleidomastoid, or in allograft. Several techniques have been described, and although satisfactory outcomes have been reported for most techniques, a figure-of-8 reconstruction appears to be biomechanically superior and may lead to better long-term outcomes. In this technique, the graft is shuttled through 3.2 millimeter drill holes in the sternum and medial end of the clavicle. Synthetic, ultra-strong synthetic braided sutures, such as orthocore, and fiber wire may be useful in augmenting the graft. The ends of the graft are then tensioned and sutured together. Any surrounding remnants of the capsule may be incorporated into the repair. This shows you drill 3.5 millimeter holes in the medial end of the clavicle and the lateral end of the manubrium, and you pass your graft in the form of a figure-of-8 and you tighten it. This has been reported to give good results. The second topic is medial physeal clavicle fractures. The medial clavicular epiphysis does not ossify until between 18 and 25 years of age. As a result, injury to the sternoclavicular joint in patients younger than 25 may actually lead to a displaced medial physeal fracture rather than a straightforward dislocation. On the right-hand side, you see a photograph, a CT scan showing you a physeal fracture dislocation. The CT scan is the investigation, in this case, of choice. Fortunately, most physeal injuries are either none or minimally displaced and rarely extend into the sternoclavicular joint. These injuries can be treated non-operatively with immobilization in a sling. Over here, you see a CT three-dimensional reconstruction of a right clavicular medial physeal fracture in a 19-year-old man. More than 50% of patients with significantly displaced fractures that are treated non-operatively end up with persistent discomfort. Some authors recommend an attempt at close reduction for posteriorly displaced fractures within 7 days of the injury. Open reduction should be reserved for injuries associated with mediastinal compressive symptoms. Medial clavicle physeal injuries are stable once reduced and usually do not require fixation. Anterior physeal injuries and posterior injuries presenting after 7 days may be treated symptomatically with a degree of remodeling possible, depending on the age of the patient. Miscellaneous causes of type 1 instability. I want to ask, are there questions? Let me see the chats, what they have. ماني شايف شيء. Okay, I'm going to go out of that. Any questions? Okay, if there's no questions, I will go into miscellaneous causes of type 1 instability. Clavicular malunion resulting in relative, be careful, relative anterior angulation of the medial end of the clavicle can give the appearance and sensation of anterior subluxation of the sternoclavicular joint. This is particularly accentuated during retraction of the scapula, and over time can lead to type 2 instability due to stretching out the anterior sternoclavicular capsule. So if you have an anterior angulation, what happens? The whole clavicle can displace anteriorly with respect to the sternoclavicular joint. So it gives you a relative dislocation or subluxation. So you have to pay attention to this. Changes in position of the clavicle secondary to malunion affect the sternoclavicular joint. They affect the scapula. This is a fracture of the midshaft of the clavicle. You can see that there are 2 points you have to pay attention. I tell you this, and I asked this in the board exam. You have an overlap of 2 centimeters. You have shortening. Does this create? It creates a stress on the sternoclavicular joint. And if it's angulated, it creates a stress on the sternoclavicular joint. And what happens? If the angulation, what position is it? Will give you the position of subluxation. The conditions which place the scapula in persistently abnormal positions, such as occurs with scoliosis. This also predisposes to atraumatic sternoclavicular joint instability. If the clavicular malunion induced sternoclavicular symptoms, these are significant, and you can do a corrective clavicular corrective osteotomy with a simultaneous sternoclavicular stabilization procedure may be necessary. So you have to pay attention to fractures of the clavicle, my fellows. This is another fracture of the midshaft of the clavicle with shortening. You have to realize if the shortening is more than 1.5 centimeters, and if it's angulated, all these affect the sternoclavicular joint. Type 2 atraumatic structural dislocation, subluxations or dislocations occurs as a result of either increased laxity or stretching out of the joint, stabilizing ligaments. It can be caused by a variety of pathologies, including conditions like I mentioned, Marfan's and Ehlers, Danlos, or those that can weaken or stretch the ligaments. And we have mentioned this in degenerative arthritis, inflammatory arthritis, infections, all these. But the most you have to keep in mind, clavicular shortening, secondary to fracture malunion. This shows you of how patient can end up having a subluxation secondary to any fracture malunion, or secondary to an inflammation, or secondary to degenerative arthritis. Keep this in mind. Keep this in mind to have a CT scan. Look at the head of the clavicle. It's posteriorly displaced. It's quite close to the trachea and the esophagus. Likewise, this shows it. So the CT scan is very important. Correct diagnosis, therefore, requires an acute, accurate history and careful local and systemic examination. In cases of capsular laxity, clinical evidence of generalized ligamentous laxity secondary to conditions, as I mentioned repeatedly, Ehlers-Danlos and Marfan's. For those who don't know what Ehlers-Danlos, it's a condition which is a collagen problem and an elastic problem. They have an abnormality, and as a result, they have extra laxity of the ligaments. Okay, be careful. And Marfan's is a genetic situation where you have a deficiency in collagens. Typically, patients present in their teens with no specific history of trauma, with a prominence and subluxation of the medial clavicle and associated pain with overhead activities. The majority of patients can be managed successfully with physiotherapy and corticosteroid injections. In the largest reported series, 29 of 37 patients, 78%, returned to full activity when treated non-operative in these patients who have laxity. 8 of the patients, 21%, had ongoing discomfort with evidence of persistent subluxation remaining in nearly all cases. The authors cautioned against the surgical treatment of these cases, as all of the patients that were managed surgically reported unsatisfactory results. Owing to the much stronger posterior capsular restraints, posterior atraumatic type 2 instability secondary to ligamentous laxity is much rarer than in the anterior. However, in a similar way to traumatic posterior dislocations, if at any point a patient's symptoms should become suggestive of retrosternal compression, an open operative reduction is indicated. Although these complications generally are observed at the time of injury, late appearing complications have also been noted after non-reduced retrosternal injuries, and these have included, I tell you, many times following a fracture of the clavicle, we have patients presenting with the thoracic outlet syndrome. Some present with brachial plexopathy. Some have subclavian artery compression. Others have exertional dyspnea. And there have been fatal sepsis following the development of a tracheoesophageal fistula. So you should realize how important these structures are. Now we come to the type 3 muscle pattern. Type 3 instability is characterized by poorly coordinated afferent and efferent neuromuscular biofeedback loops in the presence of otherwise normal musculature and structurally normal joint. The pectoralis major is the most commonly affected muscle and can be confirmed with electromyographic studies. Management focuses on learning the correct patterns of the muscle contraction, with proprioceptive feedback playing an important role. Occasionally, buttocks can be used to suppress hypertonicity in the pectoralis major if slow progress is being made with physiotherapy and treatment. Muscle patterning can also arise secondary to type 1 or 2 instabilities, making the diagnosis lie on 1-3-2-3 axis. In this situation, it is important that the biofeedback loops are addressed prior to any stabilization procedure. Buttocks should be considered routinely preoperatively in order to protect the ligamentous stabilization in the first 3 months postoperatively, should any procedure be done on the sternoclavicular joint so as to stabilize that joint. Because if there's excessive tension or traction of that muscle, it can ruin your repair. The clinical pearl: acute dislocation of the sternoclavicular joint is usually the result of a high-energy injury and should be treated expectantly. Plain radiographs are insufficient, and a CT or MRI should be undertaken. mediastinal symptoms occur in 30% of patients with a posterior dislocation, and discussion and referral onto a specialist unit should be considered. So don't forget these various techniques you can use if you use the semitendinosus stent. Now let's come to other conditions. Osteoarthritis of the sternoclavicular joint is relatively common in patients over the age of 50, and particularly in women. Many women, in invitations, they come to me and they say, feel my sternoclavicular is protruding. What do I have? Evidence of osteoarthritic changes at the sternoclavicular joint have been shown to be present on computed tomography scans in over 90% of patients over the age of 60 years. However, it is usually asymptomatic and may present as a painless lump, secondary to effusion and osteophytes. When symptomatic patients complain of pain, crepitus, and clicking, this is particularly on cross-body adduction and related to overhead sports such as tennis and golf. Non-operative treatment, including physiotherapy, non-steroidal anti-inflammatory medications, and ultrasound-guided intra-articular steroid injection are adequate in the majority of cases. Occasionally, in patients with unremitting symptoms, resection of the degenerate disc and the medial end of the clavicle are indicated. When undertaken as an open procedure, the patient may require a period of immobilization to protect the repair anterior sternoclavicular joint ligament. It is now possible to do this arthroscopically as a day case without immobilization. And this is what you can see arthroscopically. I'm not an arthroscopist, but people who do it, they say it's a simple procedure. A debridement of the joint. The results of an excision arthroplasty of the medial end of the clavicle for sternoclavicular joint osteoarthritis, whether undertaken as an open or arthroscopic procedure, are good, with over 80% of patients scoring their sternoclavicular joint as good or excellent after a minimum follow-up of 2 years. But don't overexcise too much of the clavicle. Excise just enough so as to create a space between the manubrium and the clavicle. And you will find that the patient will be completely symptom-free, and he would be so satisfied following the procedure. I have done this on many occasions, and the patients were all happy. Arthritic involvement of the sternoclavicular joint has been reported in over 30% of patients with rheumatoid arthritis and 90% of patients with severe psoriatic arthritis. The management of these conditions usually involves systemic pharmacologic suppression and local intra-articular steroid injections. However, In severely affected cases, debridement of the sternoclavicular joint and stabilization may be considered. The clinical purpose: excision arthroplasty of the medial end of the clavicle is usually I repeat, a very successful treatment for patients with symptomatic sternoclavicular joint osteoarthritis that have failed non-operative treatment. What about sternoclavicular joint disc injuries? The sternoclavicular joint is divided into medial and lateral halves by a complete fibrocartilaginous disc, which resembles a discoid meniscus in the lateral compartment of the knee. Although rare, damage to the disc can cause symptoms of pain and clicking of the joint on movement. Sometimes this clicking can be mistaken for minor anterior subluxation. In younger patients, a shearing injury results in a complex tear in the middle part of an otherwise normal disc. This can occur when the joint is both loaded and twisting, such as in serving in tennis. So you young fellows, when you're playing tennis, you can damage this meniscus. So it's not without a risk. In all the patients, there is usually pre-existing degenerative change present, and the disc usually has torn from the superior periphery of the joint. If you recall at the beginning of my lecture, I mentioned that the meniscus is joined superiorly to the upper and inner end of the clavicle and to the capsule. There are often associated degenerative articular changes present within the joint. An MRI scan can usually demonstrate a disc tear, which has a characteristic wavy appearance when compared to the normal ipsilateral side. A CT scan is not able to demonstrate the disc. An ultrasound guided cortisone injection can be tried as the first line of treatment. This is an MRI. You can see that there's an increased signal intensity at the upper end of the meniscus, which tells you that there is a tear. If this is unsuccessful, resection of the torn disc is indicated. This has previously been done as an open procedure, but can now be undertaken arthroscopically. At surgery, the whole of the disc is resected back to the stable rim. In the presence of a degenerative tear, resection of the medial end of the clavicle may also be undertaken if there are significant associated osteoarthritic symptoms. Miscellaneous sternoclavicular pathology. The sternoclavicular joint can be the focus of a desperate group of other pathologic conditions. I've repeatedly told you, inflammatory arthropathies, crystal deposition arthroplasties. You can diagnose gout at times from a swollen sternoclavicular joint. Pseudogout can attack it. Acne, pustulosis, hyperostosis, and osteitis, chronic relapsing multifocal osteomyelitis. All these can involve the sternoclavicular joint. These conditions are all rare, but the surgeon should be mindful of them as a potential differential diagnosis for a painful swollen sternoclavicular joint. Initial investigation would be screening inflammatory markers, CRP, C-reactive protein, erythrocyte sedimentation rate, and either an MRI or CT scan. In conclusion, injury around the sternoclavicular joint is relatively unusual. Injuries are usually high energy and result in instability and or fracture of the medial end of the clavicle. An understanding of the complex arrangement of the ligaments, the tendons, and muscles that stabilize the joint, and in appreciation of the posterior mediastinal structures is an essential requirement to treat these injuries successfully. Osteoarthritis of the sternoclavicular joint is very common with increasing age, but it is usually asymptomatic. Symptomatic osteoarthritis can usually be adequately treated with non-operative measures. The unusual situation where symptoms persist, excision arthroplasty of the medial end of the clavicle, either as an open or arthroscopic procedure, is usually successful. So much for the sternoclavicular joint. I think, did I bore you? يا خالد خالد
دكتور جون
ما في حدا
معك.
زهقتكم زهقتوا
لا والله بالعكس، يعني الكل مرتاحين.
خليني اقول لكم شغله. I gave you one full textbook on sternoclavicular joint during this period. Now I'm going to go into a second textbook, which is the clavicle fracture. The clavicle is derived from the early 17th century, from the Latin word clavicula. What does it mean? It means it's a small key. It is named so because of its shape and the fact that it rotates like a key on shoulder abduction. Don't forget that the clavicle has a full range of motion. It has rotation, forward displacement, backward displacement, superior displacement, inferior displacement, so on motion. The clavicle is the only long bone that lies horizontally connecting the scapula to the sternum and is entirely subcutaneous, thus easily accessible to inspection and palpation. Codman in 1934 mentions in his book the functional importance of clavicle in the development of humans. We are proud that our brains are more developed than the animals. We might also boast of our clavicles. It seems that the clavicle is one of man's greatest skeletal inheritances, for he depends to a great extent than most animals, except the apes and monkeys, on the use of his hands and arms. As far back as 400 BC, Hippocrates is said to have noted the displacement pattern of the fractured clavicle, the distal fragment sagging with the arm, meaning a drop down with the weight of the arm, and the proximal fragment moves upward, secondary to the pull of the muscles, namely the sternocleidomastoid. This is important, the trapezius muscles. And when they heal, they form a prominent callus with deformity. The traditionally held belief that these fractures could generally be treated non-operatively has been brought into question in the recent years, and the controversy over the optimal treatment has continued. Recent studies have shown a high prevalence of symptomatic malunion and non-union after non-operative treatment of displaced midshaft clavicular fractures, while some studies have shown that the shortening in a malunion may be well tolerated. A bit about the embryology. Clavicle is the first bone to ossify in the developing embryo. Keep this in mind. This is a question كل واحد مفلسف بيحب يسألها السؤال. It's a question, which is the first bone to ossify in the embryo and the only bone to ossify by intramembranous ossification. It is formed by two membranous primary ossification centers, appearing by 5 to 6 weeks and fusing approximately 1 week later. Cartilage is present at both ends of the clavicle. In time, the medial cartilaginous mass contributes more than 80% to the growth in length of the clavicle than the lateral cartilaginous mass. So it grows more medially than laterally. The sternal ossification center appears between 12 and 19 years, and it fuses relatively late by 22 to 25 years of age. McGraw et al. In 2009 have shown at 18 years of age, the mean clavicle length, plus or minus standard deviations for females, was 149 plus or minus 12 millimeters, while in males, it was 161 plus or minus 11 millimeters. So males, it grows more, and it grows more medially. They noted a statistically significant difference between the length of the right and left clavicles, though it was not clinically significant. It was 0.036 millimeters. A steady growth rate was noted for both genders from birth to the age of 12 years, and this was 8.4 millimeters per year. Above the age of 12, there were significant differences in the growth of the clavicles of girls. In the girls, it was 2.6 millimeters per year versus the boys, 5.4 millimeters per year, and P is less than 0.001. Girls achieve 80% of their clavicle length by 9 years of age, and boys 12 years of age. This could be useful in planning management of a displaced clavicular fracture in adolescent age. Anatomy. Clavicle has a double curve. We all know this. Look at the clavicle, you see that it's a double curve. You have the convexity being directed forward at the sternal end. You have a convex curve and the concavity at the scapular end. It articulates medially with the manubrium sterni and laterally with the acromion of the scapula. Its lateral third is flattened from above downward, while its medial two-thirds is rounded to prismatic form. And this is the weaker area, the medial. And that's why we get more fractures medially. Okay? This shows you the clavicle. It is convex anteriorly at the sternal end, which is shown in the figure below. Okay? And you have this various attachments of muscles and ligaments to the clavicle. The lateral third of the clavicle has two surfaces and two borders. The upper surface with attachments of the deltoid anteriorly and the trapezius posteriorly. The undersurface has two ridges, namely after the attachment of the conoid and trapezoid ligaments. The anterior border, we have the deltoid attachments. The posterior border, we have the trapezius attachments. These show you the various attachments that I have spoken about. The medial two-thirds of the clavicle has three surfaces and three borders. The anterior surface is continuous with the superior surface of the flattened portion. It is smooth, convex, and nearly subcutaneous, being covered only by the platysma. These show you the surfaces. The sternal end, you have the convex end, you have the costoclavicular ligaments as shown over here. You have attachments of the trapezius, the conoid tubercle. The trapezius is more lateral, and you have the acromial end and the sternal end. The pectoralis major and sternocleidomastoid attach medially. The posterior or cervical surface is smooth and looks backward toward the root of the neck. It gives attachment near the sternal extremity to part of the sternohyoid. The nutrient artery foramen is present on this surface. The inferior or subclavian surface is narrowed medially, but generally increases in width laterally and is continuous with the undersurface of the flat portion. On its medial part is the attachment of the costoclavicular ligament we've spoken about. The rest of this surface is occupied by a groove which gives the attachment of the subclavius. Again, we spoke about it. The anterior border provides attachment for the pectoralis major, and the superior border provides attachment to the sternocleidomastoid. So it's an important structure. So it has many muscular attachments. So it has so many clavicular or ligamentous attachments. All this, as I have repeatedly said, that this is very important in the attachment of the upper extremity to the body. It's very important in directing the motion of the scapula to resurface or to surface the glenoid in the position of function. So keep this in mind. The posterior or subclavian border gives attachment to a layer of cervical fascia which envelopes the omohyoid. The sternal end, the clavicle, is prismatic, triangular. It presents an articular facet which articulates with the mandibular sterni with articular disc. The lower part of the facet for articulation with the cartilage of the first rib. The acromial end is small, flattened, oval surface, directed obliquely downward for the articulation with the acromion of the scapula. The circumference of the articular facet is rough for the attachment of the acromioclavicular ligaments. The scapula and the clavicle are bound securely by both the acromioclavicular, the coracoclavicular, the conoid and trapezoid ligaments put together. Harrington et al. In 1993 studied the peculiar lazy S shape of the clavicle and found varying porosity and bone density along its length. They found that the most porosity and moments of inertia are located in the variably shaped sternal and acromial thirds of the bone, as opposed to the denser, smaller, and more circular central third of the bone found to be weakest part of the bone. This is attributed to the clavicle's biomechanical behavior and concur with the fracture location. Most commonly reported clinically, the function. The clavicle provides attachment to various muscles of the shoulder girdle. We know that there are 18 muscles that delight. 18 muscles around the shoulder. A good portion are attached to the clavicle. It connects the axial skeleton to the appendicular skeleton, the shoulder girdle and arm, thus provides a stable linkage of the arm trunk mechanism and contributes significantly to the power and stability of the arm and shoulder girdle, especially in movement above the shoulder level. The clavicle provides skeletal protection for the adjacent neurovascular structures and superior aspect of the lung. The subclavian artery and vein and the brachial plexus pass from the posterior-superior to the antero-inferior direction between the first rib and the clavicle at the junction of its middle and middle thirds, and are thus vulnerable during surgery and instrumentation. This shows you the subclavian artery and vein, the brachial plexus. From above, it's in front of the clavicle. They pass behind the clavicle, in between the clavicle and the first rib. Any surgery in the area endangers these structures. You have to keep this in mind. A CT arteriogram have shown that at the medial end of the clavicle, the subclavian vessels are situated behind it, with the vein intimately related to it. In some scans, the vein was opposed to the posterior cortex of the clavicle. At the middle 1/3 of the clavicle, the artery and vein are a mean of 17.02 millimeters and 12.45 millimeters from the clavicle. So they are close. They are close. One is 1.7 centimeters, the other is 1.2. And at a mean angle of 50 degrees and 70 degrees, respectively, to the horizontal. So you have to pay attention. These structures are close behind when you're operating on a fractured clavicle. In the middle third of the tubular portion, the subclavius muscle and fascia, these two protect the neurovascular structures from the fracture. At the lateral end of the clavicle, the artery and the vein are at mean distances of 63.4 millimeters and 75.67 millimeters, respectively. Epidemiology. Fractures of the clavicle are common, and they account for 2.6 to 4% of adult fractures. You can imagine it's quite common, and account for about 1/3 of injuries to the shoulder girdle. The annual incidence of clavicular fractures is estimated to be between 29 and 64 per 100,000 population per year. Fractures of the shaft account for between 69 and 82%. The lateral end of the clavicle, the fractures account for 21 to 28%, and it is rarer medially, and it is only 2 to 3%. A study by Nowak in 2000 showed that the incidence of clavicle fractures in Uppsala, Sweden, was 50 per 100,000 population. However, the incidence in the male patients was 71 per 100,000, and the incidence in female patients was 30 per 100,000. So you can imagine it's more common in males. Another Swedish study showed 68% of clavicle fractures occurred in males and 32% in females. The male to female ratio was 2.2 to 1. The mean age was 48 years. The standard deviation was 23 years. The mean age was higher in females, 59 years, and in males, 43 years. The fractures occur more often in the younger than in older individuals, with 15 to 24-year-olds, representing 21% of the study population. Males in this age group represent 17% of the total fracture burden, as many as 45% of females, but only 17% of the males 65 or older. So in the elderly, it's more common in the females, but in the young, it's more common in the males. The incidence of clavicle fractures is commonest in males less than 30 years. Why? Because they're more active, they're fighting, etc. This is attributed to the direct force trauma sustained during sporting activities. A second smaller peak of the incident occurs in elderly patients over 80 years with a slight female predominance. These fractures tend to be related to osteoporosis sustained during low-energy domestic falls. Shaft fractures occur most commonly in young adults, whereas lateral and medial end fractures are more common in older individuals. Coming to the classifications of fractures of the clavicle, the middle third of the clavicle is the common site for a fracture of the clavicle, because this is the thinnest part of the bone. You can see that the middle part is round, it is thin, it is narrower. So you have 15% along the distal third. You have 80% in the middle third, and you have 5% in the proximal third of the fracture. Ullmann classified fractures of the clavicles into 3 groups. Group 1 fractures of the middle third when there is displacement. The proximal fragment of the clavicle is usually elevated, and the shoulder with the distal fragment is displaced downwards and inwards. Group 2 fractures are distal to the coracoclavicular ligament, yani distal to the trapezoid and conoid ligaments. And group 3 fractures of the proximal end of the clavicle, these are infrequent, and if the costoclavicular ligament remains intact and attached to the outer fragment, there is little or no displacement. Neer also classified clavicular fractures into 3 groups. He said there's the mid-clavicular fracture, which is the middle third, the fracture of the distal clavicle, again 15%, and fracture of the inner clavicle, 5%. Neer subdivided the fractures of the distal clavicle into 3 different types. Type 1 is minimal displacement with intact ligaments. Type 2 is displaced with detachment of the ligaments from the proximal third, proximal fragment, and type 3 is fractures of the articular surface. So let's look at these. You can see this classification, which is now recognized, and you can see type 1 is a fracture of the outer third. It is not displaced. Type 2A is a fracture of the midshaft. The conoid and trapezoid ligaments are intact. The proximal fragment is displaced upward. And then you can have a fracture 2B, which is a injury of the clavicle, but the conoid ligament is torn, but the trapezoid remains intact. And finally, type 3 is where it's only close to the articular surface where it involves it, and it's not displaced. Neer suggested there were 4 displacing forces leading to distraction of the distal clavicle fractures and leading to a higher risk of delayed non-union. The trapezius muscle attaches upon the entire outer third of the clavicle and draws the large medial fragment posteriorly within its substance. The interposition of this muscle is common. The skin may be tented posteriorly over the end of the shaft. This shows you, just look at this. Look and try and visualize. The trapezius involves inserts on a good portion of the clavicle. When it fractures, it can pull the fragment into the substance posteriorly. The weight of the arm, as the scapula and arm descend, the outer fragment retaining its attachment to the trapezoid ligament and the acromion and is pulled downwards and forward with the rest of the arm. Let's look at this. If you have a fracture of the clavicle, the support of the clavicle does not exist, so the whole extremity will drop down, especially if the ligaments are attached to the outer fragment. The trunk muscles attaching the humerus and the scapula, these displaced the outer fragment medially towards the apex of the thorax. Rotary displacement, the scapular ligaments may rotate the outer fragment as much as 40 degrees with movement of the arm. No similar rotation of the medial fragment occurs because it is detached. So you have a difference in rotation. If you have no ligaments attached to the proximal fragment, it will not rotate. Distally, due to its attachments, as it moves down, it rotates. According to Craig's classification, he has made a long classification, and I think you should memorize it. By looking at it, you see there are so many types to each group, and you should really look at it and study it well. On the basis of Ullmann's classification, in 1990, Craig introduced a more detailed classification of clavicular fractures that was based on the variable fracture pattern seen within the three broad groups of Ullmann's clavicle fracture classification. Just to mention this briefly, Craig divided them into group 1, which is a fracture of the middle third. Group 2 is the fracture of the distal third. And in group 2, there were two types. Type 1 is minimal displacement, and one of the ligaments remains intact. And type 2, the displaced secondary to the fracture medial to the coracoclavicular ligaments. Yani, you have to pay attention to this. If the ligaments are intact, the fracture would displace distally and downward. So whether in A, you have the conoid and trapezoid attached, in B, you have the conoid torn and the trapezoid attached, and so the medial fragment will move up. Type 3 fractures involve the articular surface. Type 4 ligaments attached to the periosteum in children and displacement of the proximal fragments. This is important because in a child, you have a thick periosteum covering it. So it fractures and tears in the periosteum. So the fracture displaces through the periosteum. The periosteum, the ligaments remain attached to the periosteum. Type 5 is comminuted with ligaments attached either proximally or distally, but to an inferior comminuted fracture fragment. So that's what I'm trying to say. Memorize this classification. This is the popular classification that we are using now. Group 3 is fracture of the proximal third. Type 1 is minimal displacement. Type 2 is displaced and the ligaments ruptured. Type 3 is an intra-articular proximal fracture. Type 4 is an epiphyseal separation, which occurs in children and young adults. And finally, type 5 is a comminute. So you have to look at this. Look at the diagrams I put for you and try and apply each type to each. And this is the best way that you can memorize them. Group 1 fractures, or fractures of the middle third. They are the most common fractures and accounts for 80% of clavicular fractures. They occur at the point at which the clavicle changes to a flattened cross-section from a prismatic cross-section. This is the strongest. So as a result, the fracture occurs at this region, nearly in the midshaft of the clavicle. The force of the traumatic impact follows the curve of the clavicle and disperses it on reaching to the lateral curve. In addition, the proximal and distal fragments of the clavicle are mechanically secure by ligamentous structures and muscular attachments, whereas the central segment is relatively free. Group 2 fractures account for 12 to 15% of all clavicle fractures, and they are subclassified according to the location of the coracoclavicular ligaments relative to the fracture fragments. Type 1 fractures are the most common by a ratio of 4:1. In this fracture, the ligaments remain intact or hold the fragments together and prevent rotation, tilting, or significant displacement. This fracture is an interligamentous fracture that occurs between the conoid and trapezoid, or between the coracoclavicular and the acromioclavicular ligaments. This is to show you where it can occur either proximal to the coracoclavicular ligaments. It can occur between the conoid and trapezoid, but the conoid will be detached together with the fracture and it can displace. It can occur between the trapezoid and the joint. So you have to decide which fragments this is. Type 2 distal clavicle fractures, the coracoclavicular ligaments are detached from the medial segment. Both the conoid and trapezoid may be on the distal fragment, or the conoid ligament may be ruptured while the trapezoid ligament remains attached, as I have mentioned, to the distal fragment. I put these in detail. Type 1, both are intact, but the fracture has occurred between the trapezoid and the conoid ligament. We know that the trapezoid ligament is the portion of the coracoclavicular ligament which is laterally located. The conoid is more medially. So in group 2, type 1, the fracture is in between. In group 2A, the fracture is mesial to this, and the proximal fragment will displace dorsally, or it can also tear the conoid and likewise displace. One is either more mesial to both ligaments, or the ligament, the conoid ligament, may tear and become 2B and displace. So please memorize this. There is really no functional difference between these two fractures. The high rate of non-union in these fractures may be secondary to excessive motion at the fracture site. These fractures are equivalent to a serious acromioclavicular separation in which the normal constraints to the anteromedial rotation of the scapula relative to the clavicle are lost. This is very important. Don't forget that I mentioned that the distal fragment will rotate, while the medial fragment or the proximal fragment is not attached. So it won't rotate. This is an important factor in causing non-union of this fracture. Craig, similar to Nair, described four forces that may impair healing and may be contributing factors to the reported high incidence of non-union and act on this fracture. When the patient is erect, the outer fragment, which retains the attachment of the trapezoid ligament to the scapula through the intact acromioclavicular ligaments, is pulled downward and forward by the weight of the arm. The pectoralis major and pectoralis minor and latissimus dorsi draw the distal fragment downwards and medially, therefore causing overriding of both fragments. It's not secondary only to shortening. It is secondary to the overpull of these muscles. Remember, it's the pectoralis major, minor, and the latissimus dorsi. They pull the fragment medially. The scapula may rotate the distal fragment as the arm is moved. So keep this in mind. I've repeatedly mentioned this so that if somebody asks you what is one of the major causes why these fractures don't unite, what is the major cause why these fractures overlap? Because the pull of the pectoralis major, minor, and latissimus dorsi are mesially, and therefore they overlap and there's shortening. The trapezius muscle attaches upon the outer 2/3 of the clavicle, whereas the sternocleidomastoid attaches to the middle third, and these muscles act to draw the clavicular segment superiorly and posteriorly, often into the substance of the trapezius muscle. I mentioned this. Don't forget this. Over here, it shows you the trapezius muscle. You can see it attached to the clavicle. You can see that it can pull it into its substance, together with the sternocleidomastoid, both upward and posteriorly, while you find that all the muscles, the pectoralis major, minor, latissimus dorsi, pull the distal fragment distally, together with the scapula, and there is a rotational element. This further shows you of how the sternoclavicular ligaments, how they pull the pectoralis and latissimus dorsi, how they pull the whole fragment mesially. This explains the shortening of the fracture of the clavicle. Please don't forget this. Type 3 distal clavicle fractures involve the articular surface of the acromioclavicular joint alone. Although type 2 fractures may have an intra-articular extension, type 3 fractures are characterized by break in the articular surface between the ligament injury. You can see in the slide below, in the X-ray, of how it's totally intra-articular. A type 3 injury may be subtle or may be confused with a first-degree acromioclavicular separation and may require special views to visualize. It may in fact be manifested as late degenerative joint arthrosis of the acromioclavicular joint. In addition, it has been suggested that in weight lifters, the clavicle resorbs at the distal end of the clavicle may occur. This occurs from increased vascularity secondary to microtrauma or of microfractures that lead to such resorption. Look at the slide below. Look at the shoulder. Look at the end of the clavicle of how it's resorbed. And this occurs quite commonly in weightlifters. I've seen quite a few of these due to microtrauma and due to increased vascularity in the area. So if you're asked this question, you should know how to answer. This is a close-up view showing you the resorption of the outer end of the clavicle, secondary to increased vascularity, secondary to increased resorption, secondary to microtrauma. So keep this in mind. Type 4 fractures occur in children and may be confused with a complete acromioclavicular separation. What happens is the periosteum tears and the clavicle at the outer end is shared or tension is applied on it by the muscles and it displaces proximally and posteriorly, while a small fragment together with the periosteum are attached or remain attached to the corticoclavicular ligaments. And this is called a pseudoclaudication of the acromioclavicular joint. They typically occur in children younger than 16 years. The distal end of the clavicle is fractured and the acromioclavicular joint remains intact. In children and young adults, the attachment between bone and periosteum is relatively loose. The proximal fragment ruptures through the thin periosteum and may be displaced upwards by the muscular forces. Don't forget this, please. This shows it. You see down is the periosteum. You see the corticoclavicular ligaments attached to the clavicle. And you see that the clavicle has ruptured and it is moved upwards. Please remember that this can give you a false impression of an acromioclavicular dislocation. The corticoclavicular ligament remains attached to the periosteum or may be avulsed with a small piece of bone. Clinically and radiologically, it may be impossible to distinguish between grade 3 acromioclavicular separations and type 2 fractures of the distal end of the clavicle and type 4 fractures involving rupture of the periosteum. Group 3 fractures are fractures of the inner third of the clavicle. It constitutes 5 to 6% of the clavicle. As with distal clavicle fractures, they can be subdivided according to integrity of the ligament, the structure. You can look at the slide below. You see there are 3 types, and it all depends on where is the fracture, and you should classify them accordingly. If the costoclavicular ligaments remain intact and attached to the outer fragments, little or no displacement will develop. When these lesions occur in children, they are usually epiphyseal fractures, and in adult articular surface injuries can also lead to degenerative changes. So you have to remember many classifications: the Alman, the Craig classification, the Edinburgh classification, Edinburgh. And you have to look at the classification. You have to memorize each of the classifications. Now, I don't stress, if you know one of these classifications, for me, this is enough. But in exams, you don't know what the examiner wants most of the times. 3 different areas of fracture are identified, etc., at the diaphysis, medial and lateral ends in each of the classifications. I think each one has copied from the other. And fractures are divided into subgroups A and B depending on the displacement. So I would tell you that you should learn how to classify these fractures and have an idea on these fractures. Please, I will not go through them because this is a pure memory aspect of the fractures. Okay, so you have to pay attention. Now let's come to burst fractures. Fracture of the clavicle is one of the commonest burst injuries with an incidence of 0.5 to 7.2 per 1,000 bursts. So you should not be surprised. It's quite common. If you look at it, 7.2 per 1,000 bursts. And this is more common in breech presentations. It has an increased risk of 160 per 1,000. Other risk factors are increased burst weight for more than 3 kilos and 800 grams of larger babies that measure 52 centimeters or longer, increased maternal age, delivered by less experienced residents, and instrument delivery. Clavicle fractures in newborn are often missed and only recognized after a swelling, a callus is noticed about 7 to 11 days after birth. Sometimes a crack may be heard and felt at the time of delivery as a clue of fracture. Fractures of the clavicle are particularly common in childhood, and almost half occur in children younger than 7 years. Usually are the result of a fall on the point of the shoulder or on the outstretched hand. Sometimes the fracture may be a result of a direct blow front of the clavicle. Like other fractures of long bones, fractures of the clavicle may be one of several signs of trauma in a physically abused child. You have to think of an abused child. If you look at a child and you find fractures of both clavicles, each at a different time, or if you find a humerus fracture at one different time from the callus, and at another time you find a fractured clavicle which has healed completely, you have to think of a child abusement and you should report it. Commonly, the diagnosis is obvious. With a history of trauma, the child has pain localized to the clavicle. At times, a deformity due to displacement or angulation of the fracture may be obvious. The child is protective of the upper limb on the affected side. Fractures may only become apparent when a lump of the healing callus is noticed. Fractures in adults. Feldman proposed the classification, and he spoke about the mechanism of injury. The most common mechanism of injury is a fall on the outstretched hand, with the force being transmitted up the arm and across the glenohumeral joint and into the clavicle. So, in group 2 fractures, it occurred from a fall on the lateral aspect of the shoulder that drives the shoulder and scapula down. And group 3 fractures, or proximal clavicle fractures, are usually due to direct violence caused by a force applied from the lateral side. Stanley et al., in a series of 150 fractures, found 94% of patients had a fracture of the clavicle due to a direct blow. Only 6% of patients gave a history of a fall on the outstretched hand. So you have to think of a direct blow more than anything else. Fowler and Sankara, Cutty and Turner reported that greater than 90% of fractures were caused by a fall or a blow on the patient of the shoulder. So you have to think of these two mechanisms. A review of the Swedish fracture registry in 2014 showed the most common cause of injury was either a fall, generally on the same level, or a transport accident. Bicycle accidents were by far the most common cause among the transport accidents, followed by motorcycle accidents. Males and younger patients most commonly sustained their clavicle fractures from transport accidents in comparison to females and older patients who more often sustained their clavicle fractures from a fall. The patient will present with pain at the fracture site, be protective of the affected upper limb, and have restricted shoulder movement. There's usually swelling, bruising, and ecchymosis at the fracture site. In displaced fractures, clinical deformity may be obvious, with apparent shortening of the clavicle as compared to opposite side. The fracture may have a striking deformity, particularly if it is displaced midshaft fracture, as the weight of the shoulder arm pulls the lateral fragment caudally, whilst the sternocleidomastoid muscle pulls the medial end in a cephalad direction. The shoulder translates and rotates forward. Due to this malposition of the shoulder girdle, inspection of the patient from behind may reveal a subtle prominence of the inferior aspect of the scapula from scapular protraction as it moves with the distal fragment. I have repeatedly said this in all fractures with displacement that could happen. Shortening of the clavicle should be measured clinically, preferably with a tape measure. Measuring this length gives the difference between the involved and the normal shoulder girdle. The degree of shortening at the fracture site is said to be important in the decision-making of the operative versus non-operative care, as it has been reported in multiple studies to be of prognostic significance. Greater shortening, especially more than 1.5 to 2 centimeters, is associated with a worse prognosis. There may be bruising in the surrounding areas that might give a clue to the mechanism of injury or associated injuries. Polytrauma patients with fractures of the clavicular shaft have been found to have a mortality rate of up to 32%, mainly due to associated head and chest injuries. The high incidence of associated head and chest injuries mandates careful clinical and radiographic investigation. Despite its subcutaneous nature, open fractures of the clavicle are relatively uncommon. Most open fractures are associated with high energy vehicular trauma. There is a high incidence of associated pulmonary injuries, head injuries, scapular fractures, and facial trauma. Associated skeletal injuries can include the sternoclavicular or acromioclavicular separations or fracture dislocations through these joints. Fractures of the first rib are not infrequent and are easily overlooked. The frozen shoulder. The frozen shoulder consists of fractures of both clavicles, of both the clavicle and scapula, and is associated with an extremely unstable shoulder. If you look at the X-ray below, you see there's a fracture through the neck of the glenoid and a fracture of the clavicle. And look at the shoulder, it's displaced, mainly anteriorly. The fractures of the clavicle also be associated with disruption of the scapulothoracic articulation, manifested as swelling of the shoulder, lateral displacement of the clavicle, severe neurovascular injury, and fracture of the clavicle or the acromioclavicular or sternoclavicular joint. Haskell to realize that fractures of the clavicle are serious. They may be associated more times with other injuries, other serious injuries. They can have pneumothorax, hemothorax with the fractures due to the clavicle being close to the apical pleura and upper lung lobes, lies adjacent to bone, and they have been reported. Patients with fractures of the clavicle may have decreased breath sounds. You have to realize this, or other physical findings that suggest a pneumothorax. A thorough assessment is especially necessary in the polytrauma patient or unconscious patients. A careful neurological examination of the affected upper limb should be performed to rule out nerve injuries. Though uncommon, associated brachial plexus injuries do occur. A clavicle fracture, when presenting with an injury to the brachial plexus, a subclavian vascular injury often occurs concomitantly. Be careful, be aware. Acute vascular injuries are uncommon, but laceration, spasm, or acute compression of the subclavian vessels associated with a clavicle fracture have been reported. Though The medial end of the clavicle fractures are uncommon injuries. They have a high association with the incidence of pneumothorax, hemothorax, facial or cervical injuries. Investigation. It is essential to obtain at least 2 radiographic views to determine the displacement and or angulation of the clavicle fracture that may be difficult to assess on a single anterior-posterior radiograph. For midshaft fractures in anterior-posterior and a cephalic tilt view can be either a Zanka view or a serendipity view are important in identifying the fracture. For distal third fractures, an AP view of these shoulders, along with a cephalic tilt view and a scapular lateral view of the trauma series, may be useful. They are suggested in anterior and posterior 45-degree view. A weight-bearing AP view of Zanka with a 15-degree tilt and soft tissue technique is said to detect intra-articular fractures better than standard radiographs. This is a Zanka view. Often, rupture of the conoid ligament is obvious on radiographs because the fracture is lateral to the conoid tubercle. The corticolavicular interval is markedly increased and the fracture is markedly displaced. When both corticoclavicular ligaments are attached to the distal fragment, the fracture line is usually oblique and the corticoclavicular interval is maintained with the lateral fragment. A CT scan with 3-dimensional reconstruction may help to delineate the fracture anatomy better, especially in intra-articular extension, though often not necessary as it does not alter treatment plan. MRI scan may also demonstrate the corticoclavicular ligament integrity or attachment. Fractures of the medial third of the clavicle are better seen on cephalic tilt views, 30 to 45 degrees, or the serendipity view. A CT scan may be more useful to delineate the medial end fracture, especially intra-articular extension or epiphyseal nature of the injury. If clinically a vascular injury is suspected, an angiogram should be arranged. Treatment options and evidence of clavicular fractures, midshaft fractures, non-operative treatment. A newborn with a burst injury, little treatment is needed as usually the fracture is noticed with the onset of callus formation. Apart from keeping the baby comfortable, the fracture is well healed by 2 weeks, usually with no sequelae. Clavicle fractures in children are well known for their high potential for remodeling and healing despite their degree of displacement or angulation. Therefore, they are traditionally treated non-operatively and seem to do well with time. In children with the undisplaced green stick type of fracture, the arm on the fractured side may be rested in a sling till symptoms ease. Displaced fractures may be treated similarly till comfortable, followed by shoulder movements. Recent studies have noted that growth and remodeling potential of displaced clavicle fractures in the adolescent age group is not as predictable and may resemble that of an adult rather than that of a child. They believe that as most of the clavicle length is reached at a relatively early age, girls 80% of their clavicle by 9 and boys by 12. In consideration of the age group, high functional demand, thinner periosteal tube, limited potential for complete remodeling, and a need to return to athletic activities as quickly as possible, the authors state that adolescent clavicle fractures represent a unique injury. They have reported excellent results with minimal complication of operative treatment of completely displaced clavicle shaft fractures in the adolescent age group. Herzog looked at functional outcomes following non-operative versus operative treatment of clavicle fractures in adolescents and found an increased variability in functional measures for the non-operative group, suggests some patients may have dysfunction due to clavicle shortening. Undisplaced midshaft fractures, as well as majority of displaced or angulated fractures, which are closed injuries, are usually managed by conservative means with good outcomes. The use of a simple arm sling or the figure of 8 bandage is the most widely reported method of conservative management for a midshaft fracture of the clavicle. Anderson et al., following a reported less discomfort and trend, following a review, reported less discomfort and the trend towards fewer complications with a sling as compared to the figure of 8 bandage. And nowadays, with younger individuals, we're putting them in a sling if we do decide that they be treated conservatively. That is, that the fracture is not significantly displaced or minimally angulated. Both groups had similar clinical and functional results with either a sling or a figure of 8 bandage. However, 24% of those treated in a figure of 8 bandage were dissatisfied of the treatment method. An earlier study concluded that the functional and cosmetic sequelae of the two methods of treatment were identical and that alignment of the healed fracture was unchanged from the initial displacement with less complication in treatment with a sling. A meta-analysis by Slowacki showed that in sling versus figure of 8 for non-operative treatment of acute midshaft clavicle fractures, patients treated with the sling were more satisfied, 93 vs 74%. A recent Cochrane database systematic review that compared the figure of 8 bandage with an arm sling for treating acute middle third clavicle fractures found no clear difference between the two groups in the time to return to school or work activity. There is, however, no consensus on the optimal duration of immobilization or on the rehabilitation protocol for these fractures. Recommended periods of immobilization vary from 2 to 6 weeks, individualized to the patient's comfort level. Most authors recommend avoiding contact sports or heavy lifting for 6 months from the initial injury. Operative treatment, and I'm sure everybody wants to hear about. Although good clinical outcomes can be achieved following non-operative treatment, even after significant radiographic malunion, especially of displaced fractures, several recent studies have reported unsatisfactory results and dissatisfied patients' outcomes. Hill et al. Were one of the first to use a patient-oriented outcome measure and found 31% of patients described unsatisfactory outcome after non-operative care of displaced clavicle fractures. They reported that shortening of more than 15 millimeters, that is 1.5 centimeters, is associated with shoulder discomfort and dysfunction. The Canadian Orthopedic Trauma Society study has been pivotal in changing opinions on management of completely displaced midshaft clavicle fractures, no cortical contact between the main proximal and distal fragments. The study concluded that operative fixation of a displaced fracture of the clavicular shaft results in improved functional outcome and a lower rate of malunion and non-union compared with non-operative treatment at 1 year of follow-up. This study supports primary plate fixation of completely displaced midshaft clavicular fractures in active adult patients. A meta-analysis of 13% publications has revealed that primary operative fixation could effectively reduce the rates of non-union, symptomatic malunion, neurological symptoms, and overall complications. The clavicle trial concluded that open reduction and internal fixation is a safe and reliable intervention with superior early functional outcomes and should be considered for patients who sustain this common injury. Based on the available data from these recent studies, there is growing consensus that a certain subset of individuals would benefit from surgical intervention. The aim of surgical intervention would be to restore normal alignment and stable fixation of the displaced greater than 2 centimeters or shortening of more than 2 centimeters in the active, medically fit individual. A recent study by Goody et al. Suggests that there is no difference in outcome for patients with healed fractures with less than or equal to 2 centimeters of shortening compared with those with more than 2 centimeters shortening. It is therefore likely that many patients can adapt and function well despite this degree of deformity. However, it should be noted that this study had only 5 patients with more than 2 centimeters of shortening. You could not really arrive to a real good conclusion. The next table shows relative indications for operative treatment of clavicle fractures, which we will review. A range of implants are available for internal fixation of diaphyseal fractures, but primarily there are 2 widely accepted methods: late fixation or intramedullary devices. The relative indications include a displacement greater than 2 centimeters, shortening greater than 2 centimeters, grossly comminuted displaced fracture, open fractures with impending soft tissue compromise, a floating shoulder, polytrauma, especially associated rib fractures, vascular or neurological injury requiring repair. Any decision to treat fractures of the middle third of the clavicle operatively rather than non-operatively must carefully consider the risk factors for non-union and symptomatic malunion of non-operative treatment versus the possible complications inherent in operative treatment. These complications include deep or superficial wound infection, the risk of neurovascular injury. You have to have good experience and know where to put the fixation, know where to put the plates to avoid any vascular problem. Hardware failure, hardware-related irritation, poor cosmesis of the surgical scar. Believe me, a surgical scar in the shoulder over the clavicle is significant. Even if you do subcuticular sutures, the wound widens due to the weight of the extremities. Recent publications have shown a decline in post-surgical complications, probably resulting from improved surgical technique and implant technology. Potter concluded from their study that late reconstruction of non-union and malunion after displaced midshaft fractures of the clavicle is a reliable and reproducible procedure that results in restoration of objective muscle strength similar to that seen with immediate fixation. However, these are subtle decreases in endurance strength and outcome compared with acute fracture repair. They suggested that this should not be the sole reason to justify surgery, but could be useful in decision making. Plate fixation. Plate fixation provides stability of the fracture, pain relief, and facilitates early mobilization of the shoulder. Dynamic compression plates, pre-contoured locking plates, semitubular and reconstruction plates have all been used, though reconstruction plates and semitubular plates have largely fallen out of favor due to their weakness and potential to deform at the site of the fracture, leading to malunion. Plating provides immediate rigid stabilization of the fracture as it allows compression across the main fracture line, and if required, can be combined with the use of interfragmentary lag screws. Plate fixation also offers excellent rotational stability and maintains lens control. Golish et al. Demonstrated that plate fixation provides a superior construct, demonstrating decreased displacement at fixed loads, as well as greater loads as fixed levels of displacement during a wider range of movements. This allows for early mobilization and early accelerated rehabilitation protocols. This shows you a displaced midshaft fracture that was treated with plates. You have to be aware of the screws and of drilling because of all the structures that lie posterior. Iannotti compared biomechanical strengths of plates and intramedullary devices for diaphyseal clavicle fractures and concluded that in the presence of comminution, which is usually inferior locking plates, are advantageous as their position on the superior aspect of the clavicle bestows greater stability than in intramedullary device. Anatomic pre-contoured lock-in plates have gained prominence in recent times. They are increasingly used in displaced comminuted fractures to compress the fractures or where the fracture is bridged across using the plate as the degree of comminution does not allow for a compressed plate. They may be less prominent after healing and may lead to less incidence of hardware removal. Surgeons should be aware of the risk of injury of the underlying neurovascular structure from manipulation of the fracture, drilling of the screw hole, retracting the tissues, and placing long length screws. Some have suggested an antero-inferior placement of the plate that allows instrumentation directed away from potential dangerous infraclavicular structures and a minimal incidence of implant prominence problems. Formani found that both superior and antero-inferior techniques resulted in a similar time to radiographic union and identical union rates. They found that implant removal occurred more frequently after superior plating, but was not significant. Intramedullary fixation. Due to the sigmoid shape of the clavicle, intramedullary fixation of fractures has traditionally been difficult. There has been a range of intramedullary fixation methods for the clavicle, including Knowles pins, Rockwood pins, Hadji pins, or titanium elastic nails. There are two methods for insertion of an intramedullary device. Antegrade via an anteromedial entry point and retrograde via a posterolateral entry point. These show you the various elastic nails and plating. Intramedullary fixation offers the advantages of being a soft tissue friendly and a minimally invasive or percutaneous procedure, leading to less disruption to the periosteal blood supply and soft tissue stripping with the potential for improved cosmesis. The main disadvantage Intramedullary fixation is poor axial and rotational stability in non-transverse and comminuted fractures. In the absence of static locking, there may be shortening of the clavicle over time, more likely in comminuted fractures. Also, there have been reports of catastrophic migration of these implants, specifically smooth pins elsewhere in the body. A recent meta-analysis concluded that intramedullary fixation may be superior to plate fixation in treatment of mid-shaft clavicle fractures, with similar performance in terms of the union rate and shoulder function, better operative parameters, and fewer complications. Ran et al. In their study found that both locked intramedullary fixation and plating produce good functional results. However, metalwork may need to be removed as a second procedure in 100% of intramedullary fixation and 53% of plate fixation cases. Clinical results with intramedullary fixation or plate fixation are similar, but many surgeons prefer plate fixation for primary operative treatment of clavicle fractures or non-union because of the superior rotational and axial stability of the plate construct, especially in comminuted fractures, and not all plates need to be removed. The lateral end of the clavicle fractures, undisplaced fractures of the lateral end of the clavicle, are generally treated conservatively as they have an intact periosteal sleeve and are relatively stable due to the intact conoid and trapezoid corticoclavicular ligaments. Good results have been reported with conservative measures using analgesia and an arm sling. Displaced lateral clavicle fractures are often treated operatively, as conservative measures are usually associated with increased incidence of non-union. A systematic review of lateral clavicle fractures published in 2010 reported a 33.3% non-union rate in conservatively managed injuries and a 6% non-union rate in those treated operatively. So you have to compare and decide. Robertson et al., who examined a cohort of 127 non-operatively treated patients, concluded that non-operative treatment achieved good results in middle-aged and elderly patients, with only a small percentage, 14%, requiring delayed surgery. Low-demand elderly and frail patients are usually treated non-operatively. For the majority of younger patients with these fractures, operative treatment is more appropriate. A range of techniques are described for fixation of these injuries, including plating, hook plate, locking plates, corticoclavicular screw, Kirschner wires, and corticoclavicular ligament augmentation reconstruction. The difficulties faced during operative treatment of distal clavicle fractures is the fixation of the distal fragment. The distal fragment may have unexpected comminution or poor screw purchase. And when using anatomic plates, pre-contoured plates, this can be difficult to obtain good purchase, and this may necessitate a corticoclavicular fixation or use a hook plate. This is a hook plate fixation. You have to know how to properly use it. You have to choose the proper size. There are multiple sizes of the hook. You should not use too large or too narrow. The hook plate was specifically engineered for the acromioclavicular injuries, such as dislocations, as well as to provide operative treatment for fractures with a small distal fragment where other plating techniques would be inappropriate. Good et al. Prospectively reviewed 36 cases of distal clavicle fracture that underwent hook plate fixation as a primary procedure. The mean time to union was 3 months, with a union rate of 95%. There are concerns that the plate may induce shoulder stiffness and osteoarthritis of a acromioclavicular joint. Improper positioning of the hook may lead to a higher incidence of subacromial impingement and of acromial osteolysis. This occurs in 32 and 25% respectively. In all cases, symptoms resolved following removal of the plate. It allows early mobilization and a good subjective and objective functional outcome. A high percentage of patients treated with hook plate fixation will require plate removal. This is recommended by most surgeons, and to regain full range of shoulder motion. It is recommended to remove the hook plate in 4 to 6 months after initial insertion to avoid said complications. Pre-contoured lock plates designed for distal end clavicle fractures do overcome these acromial problems, as well as the need for routine removal of the implant. These are pre-contoured plate. At the end, they have a widened area that you can insert several screws to try and obtain absolute fixation. But at times, this is not enough, and you're forced to use a hook plate. The new plating systems have multiple options of screw fixation in the broadened lateral end of the plate, allowing for better screw purchase in the small distal fragment. Suture and sling techniques, surgical techniques involving sutures and ligament grafts have been used either alone or alongside primary fixation to good effect. This is implemented by looping sutures around the coracoid process and the distal clavicle, or by drilling holes within the clavicle. This was maintained in reduction by techniques of insertion of a tight rope band. The tight rope technique, which involves 2 endo buttons in the clavicle and coracoid, and a loop of suture material through these has been described as also demonstrated good early results for use in both fractures and dislocations. This method is useful in fractures that have a small distal end fragment or a highly comminuted fracture. Also has the added advantage of there being no need for implant removal. Also, you can use a corticoclavicular screw, but I don't like it because we've used this quite often. It's not as difficult as they say it in the literature to insert it. You have to drill widely through the clavicle because of the amount of rotation and movement in the clavicle. This creates a stress on the screw. It can either break or the screw can pull out. So you have to keep being careful about this technique. It's called the Bosworth technique. Corticoclavicular screws have been described as far back as 1941 by Bosworth as a method of treatment for clavicular stenosis. This is another screw. We used to drill wide in the clavicle, but this creates a risk for an insufficiency fracture. It is worth noting that this procedure can be technically demanding because of the small area of the coracoid that is available for screw insertion, which is associated with a higher rate of fixation failure. We hate this method. I've received many patients having had this technique, and in one, we had to remove a pin from the spinal cord, and in another, we had to remove a pin from the, even though the pins were bent. So I strongly advise against using the figure of 8 tension band technique. Personal wiring or K-wire tension banding has been used in the past. As with mid-clavicular fractures, there are problems with pin migration as well as non-union and infection. This shows you pin present in the spinal cord. So you have to be careful. Oh, et al. Described the outcome following various surgical interventions in 365 patients, and the recommended fixation was preferred due to its low complication rate compared to hook plate fixation or K-wire tension band. Medial end clavicle fractures. Medial end fractures are uncommon. They account for 3%. The medial clavicular epiphysis is one zone of the fracture. And these, most of them are treated conservatively. Fractures with anterior displaced fragments are nearly always managed non-operatively in a sling and heal well. The medial clavicle fracture with posterior displacement of the fragments may impinge on the vital structures at the root of the neck. Patients may present with difficulty in swallowing, as we have mentioned repeatedly, and this requires operative reduction. This is very important and an indication for operating on proximal distal fractures. You have to reduce it and then you treat. So be careful in these fractures. I will terminate here because I think everybody is bored by now. I think 3/4 of an hour is sufficient lecture time. I'm going to leave the floating shoulder fractures of the dislocations of the acromioclavicular joint and proximal humeral fractures in other sessions. I would discuss acromioclavicular joint displacement in sports injuries, because it is actually a sport injury. I will briefly discuss later on about floating shoulder. Maybe I'll discuss it now, get it out of the way for the discussion. Floating shoulder, what we mean by it, it's a fracture of the clavicle and fracture of the neck of the scapula. It's in ipsilateral clavicle and scapular fractures. They are commonly referred by the term floating shoulder, and this was described by Gans and Nosberger. The term was first coined by Herskovich et al. And was considered an unstable injury that requires fixation. This injury is actually a double disruption of the superior shoulder suspensory complex, the SSSC, a concept introduced by Goss that describes a bone and soft tissue ring formed by the glenoid, coracoid process, coracoclavicular ligaments, clavicle, AC joint, and the acromion. This is the SSSC, and these are the contents of it. If you look at this figure, you should keep it in mind and never forget it. This complex maintains the anatomic relationship between the upper extremity and the axial skeleton. The clavicle is the only bone connection between the two, with the scapula suspended from it by the coracoclavicular and acromioclavicular ligament. Any injury that disrupts this ring at two or more locations is considered inherently unstable. Concomitant fracture of the scapula and glenoid neck and clavicle is the commonest type of a double disruption of the SSSC. These injuries are extremely rare that result from high energy trauma associated with ipsilateral upper extremity and thoracic injuries are common. There remains considerable controversy over the optimal treatment. Owen Tal and Rickley described the excellent results in patients who had their floating shoulder treated with reduction and fixation of the clavicular fracture only. But a warning, you should use a plate in this case. An intramedullary pin would be insufficient. While Lung and Lam described a good or excellent results in 14 of 15 patients with this injury pattern following fixation of both the clavicle and the glenoid neck by applying a plate. There are case series that have reported the results of non-operative treatment in patients with ipsilateral fractures of the clavicle and glenoid who had a good result and recovery to near normal status. McKee has suggested that an operative approach may be indicated in a young, healthy individual who works overhead for a living, whereas the same fracture pattern may be treated non-operatively in elderly, low-demand patients with multiple medical comorbidities. Currently, standard operative indications include a clavicle fracture that warrants an isolation fixation, glenoid displacement of greater than 2.5 to 3 centimeters displaced intra-articular glenoid fracture extension. Patients associated indication, polytrauma with a requirement for early upper extremity weight bearing, severe glenoid angulation, retroversion, or anteversion 40 degrees. Documented ipsilateral coracoacromial and or AC ligament disruption or its equivalent, coracoid fracture, AC joint disruption. So I would terminate here, and I will start next time at non-union of this fracture, and I intend to discuss next time sporting injuries, and I will discuss the acromioclavicular joint displacements and injuries because I consider this as a sporting injury. Now, I would like to mention something. On September 7th, we have an AO course on fractures and injuries about the shoulder joint. It's an AO course on September 7th of this year. We would be glad to have people from you and from other places to come and join this course. Okay, there are many lecturers, a few international, and myself giving lectures in this meeting. So we would be glad to have you. So this is it. Khalid, don't worry. Next time I'll give you the sports injury. Okay? Khalid, سمعني؟ بس بعيد سامعك. قرب قرب. اوكي خالد اعطيني رايك كيف كان هاللكشر؟ ما عم بسمع يا خالد، ما عم بسمع. قرب، خد سبيكر very close. لأن I'm interested to know if I'm doing something wrong I will change.
تسمعني هلا؟
ايه هلا.
ايوه. المحاضرة ما شاء الله.
شو كان رأيك على هاللكشر؟
لكشر يعني أكثر من رائعة وبيستفيدوا منها الجميع، يعني سواء إحنا ولا المتدربين، ما شاء الله رائعة. وكانت يعني كل التفاصيل فيها الكلافيكل والسي يعني جوينت، وان شاء الله باذن الله البقيه تغطيها في السبورت يعني زي ما اتفقنا علشان الريفيو كورس للشباب اللي بيروحوا يمتحنوا السكي.
امتى بدك تعمل؟
ان شاء الله.
The next talk بعد
يعني
جمعتين؟
ايوه
بعد جمعتين.
اي بعد جمعتين.
اوكي. وشغله ثانيه
ولا
ايه؟ شو بدك؟ شو
الايوسباين هذا اللي الكورس بيكون في بيروت ولا؟
الكورس ببيروت. حلوه بيروت.
تمام.
ما في حالة يعني. نحن ما عندنا مشاكل صدقوني.
انا جاي من الان يعني ما يهمك، انا والشباب ان شاء الله.
It's nice to have you. ليك شغلة ثانية don't forget me. Okay? Okay. يلا.
Okay.
Bye and have a good day. Thank you.
Thank you, Doctor. كيف نتكلم الآن؟